think we'll make a start. Welcome, everyone. We have got a few more due to come in, so as they arrive, I will let them in. Just the usual protocols. The meeting is being recorded because we do get ahead of a lot of people like to actually look back on these meetings, and we're now having more views of recordings of these meetings than we're actually having people attend them, you know, which is amazing. The hits on there is absolutely overwhelming. But you know, welcome everyone. My name's Mervyn. I'm from the ITP Support Association, and with us today we have Dr. Gerard Crotty, one of our medical advisors.
Hello.
Hello, Gerard. And we've also got assisting us today some board members, Derek Elston and Anthony Hurd, plus the senior patient advisor from the ITP Support Association, Rhonda Anderson. So welcome everyone. I have got a couple of questions to kick off, but does anyone want to ask a question before we start? Has anyone got a question they'd like to get some advice on from Gerard? No? John, do you want me to read out your question, or shall I, or would you like to read it?
I think you should read it out, Mervyn, if you please.
No problem at all, sir. No problem at all. Right, this is from John, and John says he was diagnosed with ITP in 2005, and which was just monitored for a few years until his platelets dropped to below 10, and he's been on medication since then. He started on Eltrombopag in 2011, and it has kept his platelets more or less stable between 30 and 50, and he's now on 50 milligrams a day of Eltrombopag. Since 2016, he's been bothered with a very itchy rash that lasts for between 15 to 30 minutes, and his skin can get very sensitive if he presses on it. If he presses on it, he will also get a rash, and if he were to lie on a wrinkle in his pajamas, it will get very, very itchy. It looks a bit like hives, and the picture John sent actually did look a bit like hives. Would ITP or the medication cause a rash like this? Now, I know Gerard's had sight of this question. Gerard?
Yeah, well, I think first of all, for those listening who may not be familiar with this medication and so on, what has been described there is not an untypical history of ITP, where perhaps initially it doesn't need treatment and we don't treat mildly low platelet counts, but when it falls below 10 to 20, then typically treatment would be begun. And usually, certainly in Ireland, either steroids or immunoglobulin are the first line treatment, but then relatively early on, if further treatment is needed, we would come in with a second line treatment. And among the second line treatments are what's called the TPO receptor agonists, and these basically drive the bone marrow to make more platelets. And these are Eltrombopag, which is the drug that John has mentioned, Ramaplastim, which is a drug that works in a similar way but it's given by injection instead of by tablet, and there's also more recently Avatrombopag, which the name, if you use the generic names of these drugs, you realize that Eltrombopag and Avatrombopag are closely related drugs working in a very similar way. And these are among the different second line treatments for ITP. These are the most effective, really, compared to other drugs like immunosuppressive drugs. They have very high response rates. And so they will often be successful in keeping the platelet count up. But the platelet count does not have to be kept normal. It has to be kept at a safe level. And that may vary depending on your lifestyle. I mean, if you were a professional boxer, you'd want it probably higher than 30. But if for a relatively sedentary lifestyle, 30 to 50 is fine. And what John has described there is very good standard management. Now, it's a bit hard to know if this rash is due to the Eltrombopag because it's not very closely related in time. And urticaria, which is the scientific name for hives, is a common condition that can occur due to known allergens, but actually in a big proportion of cases occurs for no clear reason. And some people can get it, and we don't know why. They have just suddenly developed urticaria. And in some case, if it's severe, it can be investigated by an immunologist and treated. And in this case, if I've got the timing right, the patient was on Trombopag quite a number of years and possibly had the dose reduced before the rash started coming on. So it's not that clear. You know, if you take a tablet and a side effect starts right away and you've never had it before, then it's probably due to the tablet. To really prove that it's due to the medication, you know, a counsel of perfection would be you'd stop the medication and it would go away, and then you'd restart it and it would come back. And that would be really as close as we can get to proof that something is causing a side effect. Now, obviously, if the side effect is life-threatening, you're not going to re-challenge. You're going to stop the suspected drug and not restart it. But in this case, you know, there isn't a clear link. So it could be just urticaria that has nothing to do with the tablet. But it is, itchy rashes are reported as the side effect of Trombopag. And it is a kind of growth factor type medicine. So it is plausible that it could be causing this. The other thing is that if the symptoms are mild, you know, they might just be relatively normal. I mean, this thing where you get wheals, which is the, again, hive-like kind of swellings on the skin in response to pressure, that can be a normal finding in some people. Some people have a thing called, it's called dermographism. And anyone who knows a bit of Greek will probably know that that means writing on the skin. And basically what it means is that if you were to write on the skin, say with a biro with no ink in it, and wait a minute, the skin will come up in red kind of hives in a form that you can actually read what's been written. And that can actually just be it occurs in people who have skin allergies and urticaria, but it can also occur in people who are just normal and just have somewhat sensitive skin, perhaps just it runs in their family. So it's a bit hard to know in this case because of the long lag, whether it's related to tablets or not. I mean, if the symptoms are bothersome, I would suggest possibly seeking a dermatology opinion, because they can do further investigations and might be able to pinpoint another cause for it or treat it. I mean, you can try antihistamines. The other option would be potentially to reduce the dose of Trombopag, although if the platelet count is going as low as 30, there mightn't be a lot of scope for further reduction, but some people can reduce gradually and get completely off the drug and still maintain a good platelet, safe enough platelet count. And that's certainly an option. Or if treatment is really needed, then there is the option of changing to, if you think after all that it is due to the tablet, you could try Romiplastim, which is a similar drug, but a variant in terms of how it actually works. And it is given by injection, so it would be unlikely to have the same side effect. And I probably wouldn't, and again, this is based purely on opinion, not based on any supporting evidence really, but I probably wouldn't suggest changing from Trombopag to Trombopag, because they're so closely related that it's possibly likely that if one of them is causing a side effect, the other might also cause the same side effect. So that's kind of a long-winded answer, but you know, the hive-like rashes, urticaria, is pretty common among people who don't have ITP or aren't on medication. So it's not easy to say for sure that it's related.
Thank you, Doctor.
Before we go to Rhonda, John, have you got any comment?
Yes, I was going to just thank the doctor for his comments. And I was wondering, would the ITP itself cause the rash? And another thing is, I did try the antihistamines, but they seem to make me very dopey.
Right. I mean, there are antihistamines that are less sedative than others, and one may work. You know, there are several different antihistamines, at least a half a dozen on the market, and you may find one works and another one doesn't. And if it does make you dopey, I mean, you could try one that's just a single dose at night, where making you slightly sleepy for a few hours might be a beneficial thing, particularly if the itch is preventing you sleeping. So there are, you can adjust that and try and find one that works for you. I think ITP itself, ITP itself, of course, when the platelet count is low, or, can lead to bruising, or got various names, ecchymosis or purpura. But that looks like bruising. It's not a red inflamed swelling. It's a black and blue discoloration. And I think even from the picture, it doesn't look like that. So, I don't think it's related to the ITP itself.
Thank you.
Thanks very much, Tom. Rhonda, you got your hand up?
Yes, it says I'm muted. Can you hear me?
You can, yes.
Yeah.
Okay, thank you. Now, I was thinking when you were speaking, Gerard, about the antihistamines, and I also wondered if John has very dry skin, because if your skin is dry, it will react to lots of things, and you can use sort of moisturizing creams. Now, I have a lot of allergies and skin problems and so on, and I use moisturizing cream every day on my legs, arms, and when I go to bed on my hands. I use the others after my bath or shower. And if you're not having a bath or shower every day, then still use the cream every day. And one that I find very good is Aveeno, Aveeno. And you can get that at Boots. You don't have to have a prescription or anything. There are other ones as well, but that one, especially the one that's for babies, which has got oatmeal in it and everything, that if you look for it, you'll find it in a pharmacy, or they even sell it in Sainsbury's, actually. I don't know if you have Sainsbury's there, do you? But the supermarket, you can find it, but definitely find it in a pharmacy, and it's really, really good. And because it's suitable for babies, it's very gentle and it's worth trying. And the antihistamine that I have been prescribed, which does not make me drowsy, but I do tend to take it at night, it dries up your mouth a bit, is phenofexidine. You could ask your doctor about that. A lot of doctors say that that is the best one. The stuff that you get over the counter in Boots, it doesn't agree with me, put it that way. I know a lot of people use Claritin and Loratadine or something, but I find phenofexidine is the best thing for me, not particularly for skin complaints, but for allergy, which is things like being allergic to cats and things like that. But it's still an antihistamine, which will work for any sort of allergic reaction. And I'm not allowed to give you any medical advice, so Gerard's going to tell me if that's all right or not.
Yeah, no, actually it's fexofenadine rather than phenofexidine. So you just had it's sold under quite a lot of brand names. People will probably know some of the brand names, but again, I don't use brand names. Telfast is probably the most common brand name for fexofenadine. And yes, it is. But again, one antihistamine may suit one person and another might suit another person. Just the dry skin advice is very good advice. And in fact, it's probably advice. I tend to find that when I mention moisturizing to female patients, they're all doing it already. When I mention the male patients, moisturizer, what's that? So I think there are probably a lot of men with dry skin who have never learned to use moisturizers.
Thank you very much, Rhonda. Thank you. I've got a question from Kathleen. Kathleen, do you want me to read it out, or would you like to read it out? Kathleen is online, so I'll read it out for you, Kathleen. Right. I would just like to ask whether the product Vagifem 10 affects the platelet count, as I was assured by my gynecologist it would not. Since I've been using this product, I've now had 2 nosebleeds. And I know Gerard also had sight of this question before. And
yeah, I mean,
yeah.
So Vagifem is a topical treatment. You know, it's applied to the vagina, as the name might suggest, to treat local menopausal symptoms. And in general, it's felt not to have systemic side effects really to any significant extent at all, because it is a local medicine. It actually delivers the estrogen to that part of the body and not in any significant concentration across the rest of the body. So it's really very free from generalized side effects. So I think it's most unlikely that it would have any effect on ITP, particularly as even estrogens taken in systemic doses are not really known to have a major effect on ITP. Now, I mean, there are probably some effects of sex hormones on the actual propensity to get an autoimmune disease in the first place, because we know that during the reproductive years of a woman's life, that autoimmune diseases are more common than they are in men at that in those ages. And then conditions like ITP and many other conditions equalize in the sexes and become more common in older age then as well. So hormones may have some indirect effect on ITP, but in general don't. But the Vagifem is a hormone just delivered locally. So in my view, it probably has no connection with the bleeds or the course of the ITP.
Thank you, Gerard. Kathleen, does that answer your question?
Yes, thank you very much indeed. Thank you for that.
No problem at all. No problem at all. Right. Any other questions? Does anyone? Anthony, you got your hand up.
Yes, good evening, everyone, and Happy New Year. I just wanted to add something in from John's query or inquiry regarding itching and rashes and that sort of thing. I, like John, started my ITP journey in 2005, and during the whole period, I've been on and off of prednisolone quite a few times, and I developed shingles as a result of being immune suppressed and being on prednisolone. So it might be something that other people have encountered, or if they haven't encountered, to watch out for. So that's my experience. I got an awful bout of shingles in Christmas 2009, and it really was probably the worst thing I've had, certainly throughout my ITP career as such. But I just thought I'd throw that in. I'm sure other people may have come across that as well, and be just as aware of how painful shingles can be.
Okay, thanks, Anthony. I see Joan has put a comment in the chat. She's been living with ITP for 29 years and suffers from eczema. And she had a very severe episode of hand eczema over the last 12 weeks. And she's put some details in there, John, that may be useful for you, with a nurse helpline as well. So.
Yes, I think that's very useful, that helpline, and I'm not familiar with it, but so that's very useful information for me as well. But particularly as we don't have enough dermatologists, and it could take quite a long while to see a dermatologist. And, you know, mild skin problems, we've mentioned eczema, we've mentioned urticaria. I mean, they may not be related to ITP, but they're common conditions. And self-management plays a significant role in them. They tend to be chronic conditions, and people, to a degree, have to learn to manage it themselves if those are mild conditions. But obviously, for a more severe or bothersome conditions, seeking a dermatology referral would be a good idea.
Thank you, Gerard. Thank you. Ruth,
Yes.
you got your hand up.
Hi, good evening, everyone.
Good evening, Ruth.
And Happy New Year.
And you.
This is the first for me with ITP. I was diagnosed in 2008, shortly after being diagnosed with type 1 diabetes. I was 53, late developer. And I've also got underactive thyroid. The last couple of years, a few years ago, I was discharged from the haematology department in London, in the hospital where I was, because thank goodness my my platelet levels have been normal, above 150. Is that called remission? What's going to happen? I've had a couple of bruises, but I know I knocked my knee, so I had a bruise there. Does that mean goodbye ITP, or is it with me for life? Will it rear its ugly head again? I mean,
the answer is no one knows. It can be an unpredictable disease, and the course also varies between patients. I mean, you know, there are some patients with ITP who have had multiple relapses, and you can kind of predict that they are at high risk of having a further relapse. But then there are people who have ITP for a number of months or a number of years, and it goes away never to come back. But it can come back, you know, months or years, many years later. So I do always advise patients who have ITP that, and where they don't need very much review, if at all, to keep it in mind if they come out in bruises, that they should go and get their platelet count done, and prior to any invasive procedure. So if someone's going to do a spinal injection or a joint injection or surgery or anything like that on you, say to them, I have a history of ITP, you need to do a platelet count first. And just in case it has silently, because it is an insidious disease, it could relapse, you know, down to a platelet count of 20 or 30 without producing any symptoms. So you know, you don't want to unwittingly undergo major surgery without anyone. I presume for major surgery, it would be protocol to do a blood count anyway. But for more minor procedures, or injections into various parts of the body or dental extractions, they might not do so. Now, you know, for dental extractions, many of those, if they're modest procedures, can be done without normalizing the platelet count, but it's still good to know and get the precautions taken and get discussion with the local hematologist before proceeding with the procedure if the platelet count had gone back down again. But a lot, you know, people, I mean, I call it remission. I think there's debate about what to call it. And people who have had treatment with drugs like some of the second-line agents that we've discussed can gradually reduce their treatment and sometimes go off it completely. And, you know, you could call that treatment-free remission, or you could call it various names. I think remission is as good a name as any other, because we use that for a lot of conditions where relapse remains a possibility. I mean, I suppose if we were sure relapse was not going to occur, we'd call it cure, but we can't be sure. So I think remission is as good a word as any.
Thank you. Yeah, I know my dentist doesn't want to do anything. He's afraid to touch me. He said I had a wobbly wisdom tooth. He said, we're not going near it. You know,
yeah. Well, I mean, if your platelet count's normal, he can do what he likes with it, really, if it's needed.
What level should it be? Like if I needed an extraction of a wisdom tooth?
If it's above, in general, and assuming you're not on any anticoagulant or antiplatelet drugs for other reasons, over 50 is fine for even quite major dental work. If it was below, you know, 30 or 40, and it was a minor extraction, that might be fine with local measures. If it was a major procedure, or if the platelet count was lower, that I think discussion with the hematologist would be worthwhile. If, for instance, it might be known that you respond very quickly to, say, steroids or to immunoglobulin, and you know, a single dose of immunoglobulin or a short bout of steroids could be given just to bring the platelet count up enough to allow a procedure to safely go ahead. So those would be the sort of cutoffs I would be thinking about.
Thank you. I did ask for an annual review, an annual blood test, and I was told that in England there's a shortage of blood bottles in the NHS, and so they're not authorised to test my blood.
Right. But I mean, do you not need an annual blood test for your cholesterol?
The diabetes. Well, I asked for the diabetes, yeah, and I was told no, they haven't got enough blood bottles, so
to do it for either condition, right?
Yeah.
Okay. That's, odd.
It is odd, yeah. It is odd.
Well,
Anthony, you had your hand up, sir.
Yes, I did. With dentists, actually, it's a very good point, and it's one that I have probably raised before at other support group meetings. Dentists are not necessarily very well versed in ITP and what's needed and so on and so on. So it's a fantastic opportunity at this point to raise the subject of our treatment toolkit that we published last year. And I've given my dentist a copy of it because it is very clear then to him and all his staff as well exactly what they're dealing with in terms of ITP. So if anyone hasn't seen that toolkit, please look it up on our website. You can download a copy of it for free. Or if you want a paper copy of it, just email ITP Support Association HQ and they will gladly send you a copy of it. But it's definitely a document worth sharing with your dentist or any other health professional for that matter, because as we all know, ITP is extremely rare. Not many people will have heard of it, and even lots of health professionals won't have heard of it or certainly won't have dealt with it very often. So any opportunity you get to sort of use that document, I think it is very well worthwhile. So do so. We'll probably be able to put up a link in the chat column for people if you want to download a copy or want further information on it. So I'll type something on there in a minute.
I'll also put the link on the video link when I upload it tomorrow as well.
Yeah.
So,
also the office have various leaflets and things that you can get, and one of them is about dentistry.
Yeah.
So you could ask for that and give that to your dentist, or ask for a couple of copies so you've got one at home as well and you know exactly what it says, because yes, informing doctors is really important.
thank you.
Good stuff. Good stuff. But because
I mean, that's very useful. That toolkit, I think, is called about shared decision making. And I think, one of the things about ITP is that apart from your hematologist, who probably knows a certain amount about ITP, a lot of other health professionals in other fields won't really know much about it at all. And because it is an uncommon disorder and it doesn't present to specialties other than hematology or pediatrics really much at all. So a patient who's had ITP, particularly someone who's had ITP for a number of years and is a member of the association and has read up about it, may know more than their health professional about it. And of course, even if they don't, even if the health professional knows more, only the patient knows what their preferences are. And in terms of shared decision making, because often there are pros and cons for various decisions. And so I think shared decision making is it's not just informed consent. It's not just we decide what we're recommending and we tell you and get your consent. We in many of these situations, the decision should be a joint decision by the patient and the doctor in terms of taking into account the preferences of the patient.
Thanks
I
very
think
much,
that's fine. I think that's fine when patients are well informed, but some patients really don't know very much about ITP, and obviously they wouldn't, because until they're diagnosed, they've probably never even thought that such a thing existed. And a lot of people are diagnosed through a routine blood test. Mm-hmm. So it's also a matter of having to do your own homework, I'm afraid. So you've got work to do in order to be able to make that joint decision. And of course, that leaflet, the booklet, the shared decision-making booklet helps you with all of that.
Thanks, Rhonda. Pat and then Derek, because I saw Derek had his hand up as well. So
I was just going to mention, about physicians not being well versed in ITP. So I went to, about 4 years ago, I went to a vascular surgeon about my legs. And he says, oh, you've got ITP. You've got to have a splenectomy. I can do that. You absolutely have to have a splenectomy. I said, no, I don't. I said, I have a hematologist already. And I tell you, I rushed out of that room as quick as I could. I thought that was awful. I think that surgeon wanted to make some money.
Well, I mean, one of the things about medical specialties is that you learn a lot of things in medical school. And if it's not your specialty that you finally train in and settle in, you don't, I mean, my knowledge of surgical techniques would be related back to when I was an intern or something like that. So I wouldn't dare to recommend a surgical technique for a patient, though, because I'm a hematologist and I have been for several decades. So I stick to what I know about. But it is true that people, when doctors are speaking about something that's way outside their own specialty, they may well be decades out of date in terms of their knowledge. That's the point.
Thanks, Pat. Derek, you had your hand up?
I'm not sure I did, but never mind. I shall go in anyway. I listen to other patients' stories, and I think we've all had interesting situations. I mean, I've had ITP since the early 90s, and after various medications, I stabilized at a count of 10, came off all medications, and lived quite happily, obviously being a little more cautious than many. But I had a new GP, a young man, not long out of training, and he did a routine blood test. 3 or 4 hours later, he was on my doorstep to see if I was still alive and was I going to keel over. So he came in, we had a whiskey, and he went away feeling a lot happier than when he arrived. And now he doesn't worry. It's quite alarming. And as Jared said, people have their specialities and they can't know everything. And I think we as patients have to respect that. They specialize and they hopefully are marvelous in their own particular field. The only other thing, funny little story, when I had my heart bypass 7 years ago, and they were going to discharge me from hospital, the surgeon said, "Oh, well, we'll sign you up for warfarin now, and you can disappear." I said, "No, you won't, not with my platelet count of 10, I'll be bleeding out." "Oh, rubbish." And he sort of waltzed off anyway. The F1, who was a very nice young man, obviously still doing his training, said, "Don't worry, we won't be signing you up. I know you can't take warfarin." And of course they didn't get it. But I didn't see the consultant again. He was so browned off at being told he was wrong. Anyway, little stories make everybody feel happier, I hope.
Brilliant. Thanks, Derek. Thank you. Questions, anyone? Go on, Ruth.
Just, I avoid quinine. I mean, my husband takes tonic water because he gets muscle cramps, and I know not to touch. Is there anything else, any other food or drink that one should try and avoid besides tonic water, which contains quinine? Ibuprofen medication one shouldn't take,
yeah.
or
I mean,
aspirin.
Yeah, certainly aspirin. And now, I mean, again, none of these things are absolute. There may be patients who have ITP who also have an indication for aspirin. And as long as their platelet count is adequate to take the aspirin, I mean, above 50 would generally be considered adequate. There are patients who have ITP and are on aspirin for good reason, or on anticoagulants. And it does influence treatment in those patients because we would not like their platelet count much below 50. And whereas someone who's not on an anticoagulant, if they don't have symptoms and their lifestyle is compatible, will be happy with the platelet count down to around 20 or 30 without escalating treatment. But someone on who has to be on an anticoagulant or aspirin, we would be keener for that figure to be 50. You know, so these aren't absolutes. And again, with ibuprofen, if the platelet count is normal and there are no other contraindications, there may be nothing wrong with a short course of ibuprofen for a good reason. But just taking it willy-nilly without, particularly if the platelet count is below 50, would have some increased risk of bleeding. Quinine, quinine is associated with immune blood cell problems in some cases. I don't know that it's completely contraindicated. I'd say there's probably lots of ITP patients enjoy some tonic in their gin or the other way around without having a problem with it. But it is reported. Quinine certainly is reported to cause autoimmune problems, both with platelets and indeed other blood cells occasionally. So it may be best avoided, but I don't know that it's really an absolute. So in terms of other medication, I think we've mentioned warfarin there, other anticoagulants. So again, if someone has ITP and there is an indication to go on an anticoagulant, there has to be a serious discussion, and it depends on how pressing the need for the anticoagulant is. If you've had a major clot in your lung, a pulmonary embolus, you do need to be on an anticoagulant. And if you have ITP and the platelet count is low, then the best thing is to actually give, in the very short term, probably platelet transfusions to bring the platelet count up to around 50. And in the short and medium and ongoing term, then other treatments, steroids, immunoglobulin, eltrombopag, ramiprostim, other drugs to bring up the platelet count to above roughly 50 to allow that anticoagulant treatment to proceed for at least 3 months, which would be the minimum duration. So really, a lot of these things are not absolutes. If the other drug is absolutely needed, it may be best just to bring the platelet count up and give the other drug at the same time.
Thanks, Gerard.
Thank you.
Is that okay, Ruth? Yeah. Rhonda,
Thank you, yeah.
you got your hand up?
Yes, I get quite a lot of headaches, actually. I don't really know why. I think they're probably related to chocolate and things like that I don't eat very much. But of course, at this time of year, I have been having one or two. And I don't actually find that, that paracetamol actually really does much for my headaches. In fact, I woke up with such a bad headache a few days ago. I was going out, actually it was Friday, I was going out at 9:30 in the morning, and I thought, I really can't go out with a headache like this with COVID about. So I did a lateral flow, but I didn't have anything wrong with me, just this awful headache. And I did take paracetamol, but it didn't really do much. So I was wondering if there was anything you could recommend that people who have ITP, my platelet count is now good, so I could probably take something like ibuprofen for a day or two.
Yeah, you could. I think, as I was referring to, you could, again, with knowledge that your platelet count is good. And the other possibility, again, really probably for short-term use, but if you had a pain, be a headache or some other pain that was a bit too severe for paracetamol to work, is to take something like Solpadeine, which would be paracetamol and a low dose of codeine. But codeine is an opioid. It is a very weak opioid, but it is still an opioid. So it's and indeed there are some restrictions on how much you can get from your pharmacy here. You need to have a good story to get a sufficient dose from your pharmacist. So it isn't, but that is an alternative for someone who maybe has a very low platelet count and just can't take a non-steroidal anti-inflammatory drug like ibuprofen or diclofenac or naproxen or other drugs in that class.
So apart from the codeine and the other ibuprofen type things, there's not really much else you can have.
I suppose one of the things would be if the headaches are very frequent. There can be particular, it might be not just an ordinary stress headache or whatever. It might be, in fact, it might be a form of migraine. even if it's not, I mean, if it's on one side of the head, then it probably is migraine. But that's the origin of the term migraine, actually, hemicranium, you know, via French, half the head. So, but not all migraine is on headaches or on one side of the head. So if they're frequent and if they're associated with associated symptoms such as intolerance of the light or nausea or vomiting, they could be migraine. And there are specific drugs to both treat acute migraine and to prevent migraine that are in different classes of drugs entirely, but they don't work for general headaches. They only work for migraine. So to go to someone who can make a specific diagnosis, and if it is one of those specific types of syndromes, a variant of migraine, then there may be another treatment.
Thank you very much.
Thank you, Rhonda. Thank you. Anthony, you got your hand up?
Yeah, just one thought. Actually, I think it was Ruth that raised the issue of what we can and can't take or eat or whatever. The ITP Support Association sponsored some years ago a very broad study into ITP and nutrition conducted by Professor John Hunter at Adam Brooks Hospital, and it was a very wide-ranging study. The problem is that ITP there are so many complicated processes going on that it's very, very difficult to link any specific nutritional issues with causes of ITP. So I think that the ultimate conclusion from the study was that they couldn't find anything that might be of any issue with ITP patients. So on that wider point as to what to eat and what diet, all we can do is eat a healthy, balanced diet with plenty of fresh greens, plenty of fresh veg, avoid processed foods, avoid any ready meals if you can, cook everything from fresh, keep well hydrated. The standard advice really. Other than that, in terms of diet and nutrition, there are no other specifics really. One excellent article on food, diet, nutrition and ITP is on our, as I put on the chat here, the Platelet Disorder Support Association in the States have a very good website. If people haven't had a chance to have a look at it, please do. They've got a really good feature on food, nutrition, diet, lifestyle, that sort of thing. So worth looking at if you haven't had a chance to see that.
Thanks very much, Anthony.
Can I add to that?
Yeah.
There are branching away, is still in the nutrition area, but branching away from foods. There are nutritional supplements that people take. And of course, all sorts of, there's kind of a loophole in terms of traditional medicines, including herbal medicines that are sold as supplements in various markets, but aren't really food or supplements at all. But then there are supplements, the likes of evening primrose oil or garlic capsules, which are thought to protect against clots to some extent. I mean, they're not proven in the way a licensed medicine would be. Otherwise, they would be probably available as licensed medicines. But people sometimes mistakenly think because something's labeled a supplement that it is free from side effects. But those particular products in high dosage may slightly increase the risk of bleeding. And if your platelet count is 150, that probably makes no difference at all. But if your platelet count is struggling to reach 30, then maybe taking evening primrose oil in high dose is probably a bad idea. It may slightly increase the risk of bleeding. So I think, think about supplements. And in general, for most of us, if we eat a good diet, a good mixed diet, mainly plant-based and a good variety of food, we probably don't need any supplements. The only one probably that we might need is vitamin D, because we make most of our vitamin D from the sunshine, and most of us present live in a cloudy country. And we also were worried about skin cancer. So even when the sun is shining, we cover up and we don't let the sun fall on our skin without factor 50 sunblock in the way. So we may need to take vitamin D. But apart from vitamin D, I don't think most healthy people who have a normal working gut and have a healthy diet and a healthy appetite need to take supplements.
Thanks so much, Gerard. We have a colleague on, one of our colleagues on from the International ITP Alliance, Davey from Denmark. Davey, if you can unmute yourself, sir. Have you got anything you'd like to add? You know, what's the current position in Denmark regarding ITP or COVID?
Well, I think ITP is the same in everywhere, but COVID, well, it's like in Britain. I think it's not good. We have this Omicron variant, which has taken over completely. But the scientists believe that this wave will top in a few weeks and then hopefully disappear. I think that's the same situation more or less in the whole world, and we hope not to get another variant after Omicron.
That is true, sir. That is true.
Yeah. Can I add just my own thoughts on that? I mean, the numbers of cases of Omicron are quite staggering. I mean, the official cases in Ireland are about 25,000 per day, but it's estimated that's probably only a quarter of the true number of cases. So 100,000 cases a day. We probably have had 1 million. I mean, the official count in Ireland since the start of the pandemic has just passed 1 million proven cases. But we probably had, in truth, 1 million cases in the last month. You know, 4/5 of which have not been diagnosed on a PCR test. So, but I think particularly if you are in a vulnerable group, if you're on immunosuppressive treatment, or if you're older, you know, and by older, you know, it's very much an escalating scale. You know, being over 80 is much higher risk than being over 70. Or if you have comorbidities, if you have, you know, advanced cancer, if you have organ failure or, you know, multiple medical conditions or poorly controlled medical conditions, do try and avoid COVID. Do continue to take the precautions. I mean, there might be a tendency for people to feel, oh, well, there's so much of it now, we're all bound to get it. Well, first of all, I don't think that's true. I think, you know, a lot of people, if they're careful for the next few weeks, will hopefully not get Omicron. But also, there are new drugs coming along online, you know, available, which aren't routinely available. Now, they may be a little more available in the UK than in Ireland at the moment. These are two classes of drugs, either small molecule drugs, like you've probably heard of the Pfizer one, Paxlovid, I think, or something like that is the trade name. And there's monoclonal antibodies as well. And so it is quite likely that for someone who's in a high-risk group, if they get COVID today in Ireland, for instance, they will get what's been the standard treatment for if they're severely affected and they have to go to hospital. They'll get anticoagulation. They'll get, if their platelet count's not very low, they'll get steroids. They'll get oxygen, and they'll get all the standard management. But if you know, in a few months' time or in a couple of months' time, we may well have additional treatments that greatly reduce the risk of severe disease. So that Pfizer tablet is actually said to reduce the risk of severe complications by 90%. So I think we're, you know, continue to take precautions. You know, it might be that you might get COVID in a year's time, but maybe we'll have so much better treatment in a year's time than now that it's worth postponing it. That would be my view.
Thank you, Gerard. Thank you. Yeah, yeah. And as a person who's recently had COVID, like yourself, yeah, so I don't want it again. Thank you. Yeah, so yeah. Got a couple of bits just want to add. One of the pharma companies that we work with, Sobi, are actually looking for someone from Ireland to actually sit on a patient advisory board meeting they got due to take place on the 2nd of March. What it is that they're looking at developing a patient app for ITP. Now, if there's anyone who's on the call, who's from Ireland, who would be interested in taking part in that advisory board meeting, please drop me a line afterwards. You know, you all know my email address, mervyn@itpsupport.org.uk. But if you could think of anyone else who would possibly be interested, please let me know. So yeah, and I've got a few days before I have to get back to them. And also a couple of sad bits of news. We had two Welsh groups, you know, local support groups in Wales. One of the groups was organised on a regular basis by Mrs. Wendy Tucker. Unfortunately, I had a call on Friday last from Wendy's husband, Roberts, that she passed away through COVID a week after having her booster jab, which is very, very sad. You know, Wendy was a lovely lady, only in her mid to late 40s, you know, no age at all. Very, very sad. But we've also had a couple of other members. Dave Bagshaw, people who read the Platelet may remember David last year did an article in the Platelet about his ITP journey. He's recently passed away. And another lady, one of our long-standing members, Anne Henshaw, you know, had a lovely note from her family. She's passed away. So it is all very sad. It is all very sad. And hopefully, like, you know, sooner or later we'll be out of all this. But we are still planning at the moment to have an in-person convention in May at the Royal College of Pathologists. But with all that's going on, Adrian and I have set a deadline. The last week in January, we're actually going to make the decision of whether, you know, to remain live or revert to the virtual format like we've done for the last 2 years. And the more I speak to people, the more I'm edging more one way than the other, put it that way. So, but you know, we'll see how it goes. So, but hopefully we will have a convention, but which format it's in is at the moment undecided. So has anyone got any other questions before we close?
Can I just ask,
Pat, yeah?
John, you know, you're taking the Reveille electron bag. Yeah, but what time of the day do you take it? I mean, I find it so awkward that I have to wait 4 hours after, well, 4 hours after my last milk or something, or 2 hours before. So I end up taking mine in the middle of the night because, you know, I love tea in the morning and I have to have my milk and cereal and stuff. So if I wait till the morning to take it, then I have to wait for a couple of hours.
I take mine about 10:30 to 11 o'clock in the evening. And I haven't taken any dairy products since about 5:30. And then I won't be taking any more dairy products until the next morning. So that is the best time for me at bedtime.
Yeah. Well, that means then 6 o'clock at night, 6:30 at night, would be your last meal that contains any calcium or milk or cheese.
Yes, it would be the last time that I would be taking calcium.
Yeah, I mean, you know, it's something, it has come up at some of the ITP Support Association meetings before, and I'm not quite sure if there is any information on the website, but if there isn't, it's something that could be developed, is actually some dietary advice on menu suggestions for your late night snack or your supper that doesn't contain anything that will interact with L-Trombopag, because I think there are probably, you know, with a bit of creative thought, there are things you could substitute at that time of the day that's within the required number of hours of L-Trombopag. The other option is that if it really is a significant issue, and is avatrombopag is in the same class and does not have the dietary restrictions. So a switch of drugs could be considered. Again, I'm not sure the reimbursement situation in the UK for that. It is available here in Ireland.
Yeah, that is available in Scotland at the moment, but there's a slight delay getting approval in the UK through NICE. So yeah. But it may be available on a named person basis in the UK. I've heard a couple of cases of that. So yeah. Okay. Any last questions before we close? No. Well, thank you very, very much, everyone. Ruth, you were just going to teeter on the mute button. Go on.
No, I just want to say I'm thrilled to be able to meet people who've got ITP. I mean, I felt so lonely. I mean, thank God at the moment my platelet level is normal, but I belong to a local type 1 diabetes group, and I happened to meet there. A good friend found out that she's also got ITP and type 1 diabetes. We're now bosom pals.
Excellent.
I wanted to thank you for that. But I signed a petition the other day because there's a threat that over 60s will have to pay for their prescriptions, and I wondered, is that the case in Ireland as well, or is that just?
I believe that's just in England and possibly Wales at the moment. I believe. Yeah.
Dreadful thought. I mean,
in Ireland, people, there are different bands. There are people who have a medical card, many people on lower incomes who don't pay other than not a small fee for their prescriptions. But the rest of the population, their prescription medicines are capped per month per family, and I think the figure might be €120, or it might be slightly lower now. They've been reducing it in successive budgets and ultimately aiming to make the medicines essentially free. But at the moment, there's a thing called drug payment card or drug payment scheme, and you pay a certain amount, and beyond that you don't pay.
Yeah, there is another scheme in the UK, Ruth, where you can get a annual card, for your prescriptions. Before I had cancer, I had one of those. I think it's about £100 a year. I think it was then, and basically that covered everything for the whole year. Yeah.
Yes, because I belong to an international. It's actually again a diabetes group, and I always feel so grateful that I live here in England, that I get free prescriptions, and I don't have to worry about all the medication I get. It's free. At least I've got the stress of medical insurance. We're so fortunate. And I think it would be a terrible move if over 60s will have to pay for their medication because they'll neglect themselves.
Yeah, it's still going to be free for the over 66s.
Yeah, right.
Yeah.
I mean, every countries vary so much. Countries vary so much, and these things are incredibly complicated. In Ireland, actually, in the Republic of Ireland, diabetes is in another scheme called the long-term illness scheme, and all medications directly for diabetes are free. But ITP, despite the fact that it is a long-term illness, is not on the long-term illness scheme. So there are complicated rules, and they are incompatible in different countries. So they keep governments keep tinkering with the rules, and instead of simplifying the system, they end up adding on bits here and there and making it very complicated.
Okay, right. One final point before I close. Just like to announce as well that in future meetings we hope to have a new medical advisor join us from the Republic of Ireland, Dr. Beatrice Nolan. Beatrix is a consultant haematologist with an interest in paediatric ITP, and she contacted us a few weeks ago, just before Christmas, and she's happy to join us as one of our advisors. So hopefully in future meetings Beatrice will be on board as well. So that's brilliant news. But thank you, Gerard. Thank you everyone for joining today. I hope you found it useful, and hope to see you all again. And in the next couple of weeks we'll set some more dates up for future meetings. Thank you very much, everyone. Take care.
Thank you.
Bye-bye.
Thank you, everybody.
Thank you. Davey.
Thank you so much.
Bye-bye.